through the first two presentations, the connection that eHealth has to the LIN agenda and the desire of the LIN to build an health system supported by eHealth. Where the presentation from Doug explains where the eHealth strategy for Ontario really links to and makes connections to delivering care. Hopefully through this you'll see how our local strategy links to that and start to build some of those connections among the groups. Now, before I go on, I just want to do a quick show of hands. How many of you are here from a community support agency? You'll note I did start with hospitals. Mental health and addictions. Some type of primary care, FITFOs, CHCs, other organizations. Great. Long-term care? CCAC? Other? Okay, hospitals. Great. I think you can see it's a good mix, and I'm really excited that we have so many reps from our community. What I'll try and do, the reason I ask, is try and tailor some of the presentation. I've got a couple examples on what eHealth might mean to you, so if I don't hit your group or you want to stick your hand up and ask me some other questions, that'd be great. And I think, as Doug said, how we roll this out will be very much dependent on the region and the priorities, so it will be impacted a bit on what our needs are. I'm just going to very quickly touch on the vision and direction. We'll have these slides available, so I don't really want to go into them in detail, and I think Sherry's done an excellent job of covering off where the LIN's going. I just want to note a couple things on the direction. Really, we're trying to look at three things out of eHealth. The main one, I guess the first one, is helping to provide relevant information that will help with healthcare. So really, it's the right information about the right person to the right provider at the right time. And if we can help deliver that, then we feel, and I think literature shows, we can help to improve care. The second point, and Doug touched on this, it's largely at the provincial level still being worked out, but I think locally, you're going to see a presentation from Janelle this afternoon on the Inter-Cha tool that's helping us do some of this, which is really get the information back that we can start to measure how we're performing as a system and as an agency, and not having to collect separate data, but having data that's used for that being driven as a result of providing care. And lastly, the LIN's looking to support back office integration and the sharing of resources, the sharing of systems so we can improve efficiencies and be able to support going forward the eHealth agenda. So that's really the direction and where we've tried to put our focus around projects. We've come up with some guiding principles. Again, I'm not going to read through these, but I just want to touch on a few of them, and hopefully by the end of the day you'll feel comfortable that we are aligned with the provincial strategy, that the provincial strategy for eHealth is aligned with the Ministry of Health strategy, and that's really to meet the needs of the citizens. So we're not about going out and doing our own thing within the LIN. We frankly don't have the time nor the money to do that and really want to take advantage of whatever the province is doing. Solutions will be developed to meet clinical and business needs with clinician input. You'll see a presentation this afternoon from Janet around an infection control system that the infection control practitioners in each of the hospitals it's aimed at really are quite excited about the chance to get something that we can use locally and then integrate across the LIN. Implementation will be managed as a system through LIN eHealth governance, standards, and coordination. I'll speak to this a bit more in a minute, but really this is about starting to build the system. So this isn't about going to Doug hat in hand and asking for X million dollars so Gananoque Memorial Hospital can put in a new system. It's about how do we approach this from a LIN as a system, cooperate with other LINs, and with the province so that we can build things out. Development will be based on provincial standards, regional standards where we need them, so that does a good job of covering off why that's important. And boldly build on existing innovation, but look to reduce the number of systems in place. And I'll speak to that one and the impact in a second. And this is the impact in terms of current state. So the current eHealth system, and I use that word loosely in southeastern Ontario. So Doug, we do have two hospitals that share an electronic patient record, so KGH and Hotel Dieu are integrated from an eHealth point of view. But all the others at this point are standalone. There's a lot of work going on to bring those together. We have various flavors of different systems, so we may have hospitals using the same system, but in different ways. Then also within the hospitals, there's numerous departmental systems. I think at one point the count in KGH was up over 20. So as much as they're bringing everything together, there's still a fairly wide variety of what's out there. Physicians can choose from a variety of electronic medical record systems. We believe there's about 7 different ones within the LIN. Now the good news is that 7 hasn't increased in a couple of years, so we're not adding to the diversity, but there's still a number of them out there. CHCs have a different system that is managed for them. I use that term managed loosely. I think my CHC people out there would agree. Implemented and supported provincially. So one of the projects we've been working on with other lens and with the ministry is looking at that CHC system and what we can do to support the CHC. CCACs have recently moved to one shared client management system, so before that there was 2.5. We can discuss how you get half of the system later, but they now have moved to one, so we're being able to move forward in that. However, it is a system that isn't off the shelf. It was built and maintained by a provincial body, so again, our ability to influence that is somewhat limited. And in the other areas, community support, long-term care, mental health, and addiction, there's numerous client record or client management systems out there, and some sites are starting to move to share systems, which I think is very positive. But if you look at this, we have a lot of systems out there, even the ones people that have the same flavor have it implemented differently. And so integration, as Doug spoke to, is going to be a challenge. And that's really the main implication. We have significant investments made in e-health systems. So it's not something we're going to go in and rip out. So I guess the first thing, message for everyone to walk away from, I don't have money, Doug doesn't have money, Sherry doesn't have money to replace your system. So you bought it, we're going to live with it, we're going to hopefully improve it, we're going to ask you to share with other people, and we'll build on our successes. But we aren't looking to rip and replace everything. If you're interested in that discussion over some adult beverages, interesting case studies of what's going on in England, in the UK in terms of rip and replace and whether they're actually any further ahead than we are with that strategy. They've also had their own e-health scandals. There's a variety of systems, and it makes integration a challenge. Really the challenge is around the different vendors. I think anyone that's dealt with any type of computer vendor knows they can be difficult pieces to deal with, and when you start to deal with multiple vendors to try and integrate information, it just makes things difficult. There are different approaches to sharing. So in some cases, like KGH and Hotel do, they've very much integrated a system. Trying to strive for, you really don't know where you are in terms of which hospital you're at, but the information is the same. Other sharing is a little bit different, where you might share a computer server, but you really wouldn't know that the two systems are shared. And some people have used different standards. So not only amongst the sectors, but within individual sectors, different standards around just the simple things like registering a patient. How do you take name, address, phone number? And I think as we talked about, there will be no single e-health record, and I'm going to build a little bit on that in my next few slides. So this is a slide that Yasmin looked at and said, what the heck is this all about? Well, she didn't use those words, but this is my elephant. So I started to refer to it as the EHR elephant. I'm just going to take a second to explain a couple things why I think it's a good analogy, aside from the fact that I like the alliteration. If you talk about elephants, the proverbial story about the blind men and the elephants and trying to describe it, the first man, he felt the side of the elephant, and he was clear, it's a wall. This thing's a wall, it's going to be a wall, and that's what it is. Next man grabbed the leg, and he had a tree trunk. The man that grabbed the trunk was sure it was a fire hose. The person that got stuck on the end of the tuft was sure they were dealing with a spear. And the guy that grabbed hold of the tail, well, he wasn't sure where he was. But the vision of an e-health record is the same. It's going to be different depending on what you look at and what part of it, and that's okay. But when you take a step back and look at it from a systems point of view, we have to remember it's still an elephant. And the other piece thing about the elephant is, how do you eat an elephant? One bite at a time. And it's the same thing with an e-health record. It's going to be a long journey, but we have to parcel it up into pieces. I'll speak to what we think some of our pieces are over the next 5 years, and gnaw your way through it quite literally. So, again, you can leave with the EHR elephant. We're all going to see things a little bit differently, and it's going to take a long time to eat it.